Good afternoon. Welcome to Heart Rhythm TV. I'm delighted to welcome this afternoon Jared Bunch and Thomas Deering to discuss the document regarding atrial fibrillation centers of excellence. Good afternoon, gentlemen.
Good afternoon.
Thanks for joining me. Let's start off by discussing what's the need to define a center of excellence for atrial fibrillation management.
Well, and I think we recognize that atrial fibrillation care is just becoming much more complex, not only for us as electrophysiologists, but for the whole medical community that touches them over time. And it's becoming increasingly hard to adhere to guideline concordant care. And also when you bring in risk factor modification, where a lot of people aren't comfortable with it, we needed to put together a framework to create idolized teams that can address atrial fibrillation at the first visit, how to move them through a process in an institution that is aligned with that care, and then how to really evaluate, perform and get the best outcomes, and evaluate and reassure yourself that you are adherent to those. So it really became a framework of how can we, in a methodical way, put together a framework to idolize atrial fibrillation care.
Well said. Can you tell us how the current document that's available came into being? Who was involved in producing it, and what the process was by which it came about?
Sure. This is actually the third iteration of the process. John Piccini was the first author on our first document, which basically looked at the rationale. Why do we need to have a center of excellence? Which I think is, the first foundational thing we need to address. In a, web-based manner, Elliot Ottman at the Brigham and Women's Hospital in Boston put together the how. This is how you build it. These are the things you need to do to make it come into fruition. And this really addresses the what. How do you make it work? What metrics do you have that can make it functional and make it excellent? And how do you measure? How do you establish continuous quality improvement? What teams do you need to bring together? So we went from the rationale of the why to the how to the what. We still have a lot of work to do, but that was really how it came together.
Absolutely. And I think the document speaks of 5 key pillars that make up an AFib Center of Excellence. Perhaps we could talk about what those 5 key pillars are and what's involved in them.
When they're framed upon this concept, we need to get the right person in the right place at the right time.
Yep.
And so we know that everything we do is better early on, but we also know that morbidities associated with atrial fibrillation develop on that first touch point we have with someone that's diagnosed with atrial fibrillation.
Cool.
So really the pillars are first founded on the new document, the guidelines from both the American FHRS, AHA, ACCC guidelines, but also the European guidelines that said we need to prevent stroke well and recognize and identify people early. We need to minimize risk of heart failure and treat heart failure, but we also then have to begin early rhythm control in those that are candidates, and risk factor modification, not only at the time that you see them, but looking back throughout the journey, which is of the chronic disease of atrial fibrillation. So these pillars then become, how do we materialize them in a system? And that includes finding a champion that can champion the care of the patient, but then linking them with the key team members to address those things. We need nutritionists, sleep medicine people, vascular medicine, surgical colleagues. We need exercise physiologists. All of these people have to come together, and we all have a different stake in the care, but we all have to come together in a unified way that sometimes isn't reimbursed well, but ultimately leads to the best outcomes for the patient.
I think that's well said, Jared. And the couple of things I might add to that is, if you look at the European document in care, and we really want to make sure that we are continually evaluating where we are, because it's going to be a CQI process. We will be better tomorrow than we were yesterday, but we've got to keep looking at what we did, what we did well, how we can continue to make it go forward. And then I would argue the underlying principle is access to everybody all the time to the right doctor, just like you said. So, you know, if you can't get access, you can't get the care that you need. So that's the underlying pillars, that everybody, whether you're in a rural area or a suburban area, an inner city, you know, independent of your background, your economic, socioeconomic situation, you need to be able to have access to all. And that really is a driving force for this type of document. So a Center of Excellence is expected to really reach out and try to ensure that all patients in their purview do get appropriate access to the right person.
Who's responsible for the awarding of the Center of Excellence status? You know, what's the process?
Well, we at present don't have an award, you know, and I think this is a work in progress.
Right.
You know, what we're trying to do with this document is get out the information on what you need to do to fill the different check boxes, to identify the gaps and start filling them. I do think over time we will start moving in that direction, and it would be the Heart Rhythm Society, I would argue, that would be the organization that would do that, but it also might depend on, you know, the different components thereof. So for example, if you're a rural institution that is part of a larger system, do you make appropriate referrals? Do you do the guideline-driven things that are simple that you can do, like oral anticoagulant therapy, appropriate rate control, you know, et cetera? So if you're a tertiary or quaternary center, it might be related to, yes, doing those things, but doing ablation effectively, according to the guidelines, with good outcomes and low complications. So I think we haven't established exactly yet what that will turn into, but I think that as we go in the direction, there will be a cooperative between those that are at lower end and those that are higher end, and probably components that will define meeting those particular aspects. Jared, what are your thoughts?
No, I agree, but we did two things with anticipation of that. One is, in the document is actually a checklist, so you can not only see where you are right now, but also see where you need to go. But we also recognize that centers are in a big spectrum across the world, and some do things very well and others not so well right now. And so we set up basically tiers of performance, and the base performance sets the stage for the next performance. And so if you begin here, what do you need to be at the next? So you're going from bronze to silver, silver to gold, and how you perform. And so the framework is there to create it, to self-administer. And then the next step is, should there be a certification body and things? We're not there yet because we needed the framework, but then that's obviously the next question and the next step, and how do you execute that, and who does it, and who will do it best. But
I agree, Jared.
Is the thought that once a Center of Excellence is awarded, that will be something that needs maintenance of certification? Is it the kind of thing that would get looked at every 5 years or 10 years or something like that? Would that be the thought?
Well, we had two issues with the document, two things that I thought were critical. One is we want continuous quality improvements. That means collecting data, analyzing the data, and allowing that to change. And so that has to be part of this. The frequency we don't know yet, but we also wanted to give physicians where they can go to their administrator and say, look, this is essential to care. I need the resources to do quality improvement. I need the resources to do quality care. I need these colleagues. And we're going to look back at periods of time to make sure you have a return on your investment. And we're going to measure it in XYZ way. And so part of this was also to arm the physicians in their hospital to overcome barriers for this multi-specialty care, this recurrent and longitudinal analysis that drives improvements.
No, I agree with you. And that is oftentimes, Oliver, a barrier to entry or a barrier to improvement. Sure. Is institutions, because of all the factors that are out there and all the things that they're trying to prioritize, you know, can't do everything all the time. But if we can say, and this is what you need to do to remain a center, not just become a center, and that will change based on science, based on guideline updates, et cetera. But, you know, we anticipate that people will be able to do that, and it's a continual, you know, process in CQI. And I think that's going to help us to make sure that people and institutions, you know, do that.
Right. What do you say to people who would say, you know, we feel like we do a pretty good job of managing our AFib patients now? What do you think that the definition of centers of excellence adds or offers to patients and providers over and above what people do now?
Well, I think like what we said, the checklist is very important.
Right.
Because you can look and say, okay, here are these things in this group or that group, and I'm fitting and doing them well. But even within that, you've got to really do an internal look, in my opinion. You've got to say, are we really doing it as well as we think we are? Are we really using the appropriate guideline-driven type things? And I think the key to patience is, if I'm going to make a decision about where I'm going to get my AF care, I want to go to a place that is adhering to the science, performing according to what the guidelines say you should do. And if a center says we're doing these things, they are more likely to get better care, because it starts with access, and then it starts with all the different pillars and achieving the various components. And whether you're doing simple things like managing for rate control, or whether you're doing more complex things like a second ablation, you've got to do everything in the right way. So the communication, in my opinion, to the patient is, we are doing the right thing. We have looked at the metrics. We're making sure that we're going in the right direction. You can feel confident that we're going to do that. And we'll make mistakes. We will need to continuously improve, but we are committed to that process. I don't know, Jared, what are your thoughts?
No, I agree. And part of the advocacy of the document is, this is the top line care that we can idolize right now. So we've taken numerous specialists from around the world and said, let's put together in a format the best way to treat atrial fibrillation patients, and make it and distill it into steps for institutions. And I think that gives us a assurance that we're doing what's right in a contemporary manner, but also provides something to grow on as we get new technologies and evolve. And I think centers do well, but we often have this internal bias that we're doing better than we are. And ERA sent out this really nice survey to young cardiologists and electrophysiologists that these are what we need to do for risk factor modification, for anticoagulation, for weight loss, smoking cessation, for assessing mood and psychological distress. And almost in every question, the young doctor said, we have a ton of institutional barriers. I have personal barriers that I have no comfort in telling somebody how to get their mood better or how to eat better.
Exactly.
And so I think when we look, we see the big deficit of where we want to be and where we are currently. And this kind of fits the void of the two, how we can get there between this gap.
And I think the other thing for patients, Oliver, just to add an additional component is, if you live 200 miles away or 50 miles away from an urban center, you can get the routine things done, and you have an open communication network with the higher end place. Right. And if you're part of an institution, but you're a smaller component thereof, these people are doing the right thing. So it instills in patients confidence that, gee, when I go to this outside place, I'm still getting the best care that I can. And I know that if I need more additional care that they can't deliver, I will get sent internally. Right. So I think it establishes that whole matrix of a connected network for patients to drive things in a positive way.
Absolutely. Well, I'd like to congratulate you both on what is a very needful and comprehensive document. Doing the right things for our AFib patients is absolutely critical, of course, and your document provides a beautiful framework for us all to be able to do that across the nation. So thanks very much indeed, and thanks for joining us this afternoon.
It was an honor to be here. Thank you.